Every single year in the United States, medical laboratories issue over 82 million surgical pathology and cytology reports. These documents dictate whether millions of patients will undergo major surgery, prolonged hospitalization, or aggressive chemotherapy. Yet multi-institutional studies reveal a severe gap in how effectively these files communicate. When tested on the contents of reports they had just read, clinicians incorrectly specified 30% of the pathology information. Poor physical arrangement of text on the page drives these errors, even when the clinical data itself is complete. Look at this standard specimen-centered surgical pathology report. If you read closely through the dense, unformatted paragraph D, you will find a diagnosis of conventional type adenocarcinoma. It is remarkably easy for a clinician scanning for results to miss the cancer diagnosis entirely. The geometric layout of clinical text functions as a high-stakes patient safety vector. It requires the same level of precise engineering as the medical procedures it guides. We can treat the fidelity of clinical communication as a solvable engineering problem. To do this, we look to empirical design principles established by 3 fields that specialize in rapid, accurate data processing. First, commercial aviation, next, print journalism, and cognitive psychology. By translating the core lessons from these disciplines, we can systematically redesign flawed medical documents. We are going to take the dangerous, cluttered pathology report we just looked at and rebuild it from the ground up. Treating a medical record as a carefully engineered interface directly addresses the cognitive bottlenecks that lead to communication failure. This New York Times front page demonstrates the inverted pyramid layout utilized by the publishing industry. Vital information is conveyed instantly at the top. Notice how strategic visual white space sets this primary message completely apart from the supporting text block below. A multi-biopsy pathology report requires the same overarching narrative focus, rather than assigning equal weight to every individual tissue specimen tested. Here's our standard unformatted pathology report again. We have a dense block of text listing 6 individual prostate biopsies sequentially. Out of all these lines, there is a single actionable finding: the patient has cancer. Elevating that diagnosis to the top of the document and surrounding it with white space creates a patient-centered format. The headline does the heavy lifting before the reader even reaches the granular details of the specific biopsies. An absence of disease in a post-surgical excision must also be formatted as a diagnostic headline, ensuring the actionable clinical takeaway is impossible to overlook. Inside this cockpit is the standard 6-pack gauge cluster. Shortly after World War II, flight instruments were standardized into this uniform array. Because gauges are identically positioned, pilots rely on a spatial spotlight. They know exactly where to look for altitude without reading every dial. Clinicians reviewing pathology reports under extreme time pressure rely on a similar mechanism. This diagram illustrates how pathology reports must utilize consistent spatial positioning for core fields like patient data, physician details, and diagnoses. When spatial expectations are broken, patient risk rises. Controlled studies show changing an established format increased clinician recall errors by up to 54%. Maintaining strict layout continuity across an entire hospital system is far more important than internal debates over whether the diagnosis belongs at the top or bottom. Human working memory is strictly constrained. It can only hold a few discrete items at a time, and without mental rehearsal, that data decays in a matter of tens of seconds. We bypass these biological limits through a psychological mechanism called chunking. As 12 random numbers group into 3 familiar 4-digit sequences, memory load compresses, storing more data simultaneously. In a clinical setting, specialist pathologists quickly chunk dense diagnostic strings into a single mental unit. Forcing tightly packed, unchunked text strings onto non-specialist readers guarantees that critical data will exceed their working memory and be lost. We can further optimize information density by changing data dimensionality. Working memory processes 2-dimensional spatial representations much more efficiently than 1-dimensional text arrays. Mapping positive biopsy locations onto an anatomical diagram requires less time to process disease spread, and recall errors drop sharply. Report formatting must explicitly match both the density and the dimensionality of the data to the specific expertise level of the person reading it. To protect that limited working memory, we must eliminate distractors. A distractor is any visual or textual input that interferes with the mental rehearsal required for short-term retention. Look at this Stroop effect test. When the semantic meaning of the word conflicts with the color of the ink, the resulting cognitive interference noticeably slows down your ability to acquire the data. In medical documents, arbitrary font changes, unnecessary highlight colors, and redundant diagnostic minutiae act exactly like the Stroop test. They create clinical cognitive interference. Look closely at Section B of our redesigned report. The streamlined format completely removes redundant prefix labels that clutter the page. Because the physical position of the data is standardized, the reader implicitly understands the context. Structural location alone defines content, making explanatory labels obsolete. Human executive capacity is strictly limited. Stripping away non-essential data and visual clutter is a mandatory safety requirement for effective medical reporting. On the top, we have the original, unformatted clinical text block. On the bottom, we have the systematically engineered report. The diagnostic headline instantly captures attention, isolating the cancer diagnosis from the background noise. Optimized data density, strict layout continuity, and a complete lack of visual clutter guide the clinician's eye flawlessly through the supporting details, like the Gleason score and tumor size. These four principles work together as a single system to remove the cognitive friction that previously caused readers to miss critical information. This transformation alters the speed, fidelity, and accuracy of data transfer between the laboratory and the treating physician. When a physician fails to grasp the contents of a dense, poorly structured medical report, it is common in the profession to blame the individual's competency. But when a malignant diagnosis is missed because it is buried in a cluttered paragraph, the fault lies with the system's design. We do not expect commercial pilots to interpret poorly arranged flight dials while trying to land a plane. When critical information is misread in a high-stress, dynamic environment, the aviation industry blames the interface, redesigns the display, and prioritizes the user's cognitive limits. Medicine must adopt the same standard. If a clinician cannot instantly extract the clinical truth, the diagnostic report itself must be rebuilt.